Hello, hello. One second, one second, one second. One second, one second, one second.
Good morning, Suresh sir.
Hi, Naresh.
Thank you for joining and accepting our invitation for the World Stroke Day. I know that you are has been continuously been connected with you for
Yes.
most of the times. She conducts lots of programs, and hopefully she has given you all the instructions and given the guidelines to you, like whatever the connections we can make.
Yes.
Thank you, sir. It's your time. You can start your presentations.
Sure.
Thank you, sir.
Thank you so much, Naresh, for the opportunity. Thank you, Balamurugan sir, for this opportunity as well. And thank you, Tamil, for all the support. I'm linked in and I'm able to now talk to you all. Hope my voice is audible.
Yeah, it's an audible, sir.
Is it possible to see the participants or everybody is online?
Okay, can you start it now, sir?
Yes, please. Yeah, sure. If I could see the participant, then it would be nice.
Okay, good morning, everyone. I am Tamilarasi, working as an assistant professor in SREE ABIRAMI College of Occupational Therapy, and I will be the host for this session. I am honored to welcome you to today's webinar, sir. Before we begin, I would like to take a moment to express my gratitude to our esteemed leadership, Dr. Iswami, sir, for his visionary guidance and unwavering support in driving our organization's growth and excellence. I would also like to extend my appreciation to our director, Dr. Kundavi Devi ma'am, Dr. Sendil Kumar sir, Dr. Balamurugan sir, Dr. Uma Devi ma'am, Dr. Sucharita ma'am for their invaluable insights and commitment to our organization's success. Their leadership and direction have been instrumental in shaping our organization's mission and value. I would like to thank our principal, Dr. Naresh Babu sir, who motivated them to the dedication to our professional development and growth. With that, I would like to welcome our speaker, Dr. SURESKUMAR KAMALAKANNAN sir. He is an associate professor of rehabilitation University, Newcastle, UK, and honorary associate professor at the London School of Hygiene and Tropical Medicine. He is the trustee of Royal College of Occupational Therapy in the UK, the UK delegate for the World Federation of Occupational Therapy. He is an associate editor for the British Journal of Occupational Therapy. He leads organization and contributes to integrating rehabilitation in health system and policy research globally in many ways. He is the director for the Coherent India Network Alliance for Public Health and Disability, a scientific committee member of the International Stroke Rehabilitation and Recovery Alliance, a founding member of the Global Consortium for Stroke Rehabilitation, a member of the research work stream of the WHO World Rehabilitation Alliance, the member of the board of Global Occupational Therapists Think and the Indian Occupational Therapists Think Tank. So he has published extensively in international high impact journals, and his research high index score is 80, which is more than the scores for 90% of rehabilitation research globally. He is the only one occupational therapist from India leading and contributing to national and global stroke care. World Stroke Day, observed on October 29th, this global initiative aimed at raising awareness about stroke prevention, treatment, and recovery. This year, the World Stroke Organization has introduced the inspiring campaign theme Greater Than Stroke. It's my pleasure to hand over the webinar to our esteemed presenter, Dr. SURESKUMAR KAMALAKANNAN, who will share his insight on ensuring continuum of care for stroke survivors in India. Please proceed, sir.
Thank you, Dr. Tamilarisi, for the generous introduction. I just want to know, do you want me to move the slides, or I have forwarded the slides to Dr. Naresh as well. So would you be moving the slides from your end?
Yeah, you can share it PPT also, sir. We can see it here. And later on, we'll get it, the PPT from Naresh, from you also.
Is it possible to turn the screen for me to see the audience, ma'am? Will that be possible?
Yes, sir. Yes.
Go to the presentation mode and I'll start presenting. Any information that you can give me on who are the audience in front in the hall? Is it only final year students, or it's only from occupational therapy? You're on mute, ma'am. Sorry.
All the final years, second years, and third years are participating from Physiotherapy College and Occupational Therapy College students.
Fantastic. Fantastic. Thank you, ma'am. Thanks for that information. I'll start presenting now. Just let me know if this is coming as full screen for you. Can you see the full screen?
Yes, sir, we can see.
Thank you, ma'am. Thank you. I'll start. So firstly, once again, I would like to thank the organizing committee of this particular Stroke Day celebration, and thank you all for the opportunity to speak in front of you all on this important day, on an important topic for stroke survivors in India. You're all passionate professionals, or going to be passionate professionals soon. So I won't take much time to talk about theories. I will actually talk about a little bit of what is stroke for everybody. I thought first years also will be there, so they might not understand. So I'll just give a little bit of introduction to what is stroke, and then I'll get into something called hard facts. So as healthcare professionals, you all have to understand not just from theories and from the teaching related to how good stroke rehabilitation can be provided. You should also be able to understand what exactly happens in India for somebody who's affected by stroke, particularly in the rural regions of our country, what happens for stroke rehabilitation and how care is provided. So I'll talk a little bit about that, and then how I have taken a step to address this issue of accessibility to stroke rehabilitation and care. What role can we play and what possibilities are there for us, and the way forward. So this is going to be the outline of my presentation.
Can you please put your slides there?
Hello?
Slides there, sir, because we can see the screen fully.
It's not. Hold on a minute. Can you see this? It is in full screen. Is it not going to full screen now?
Yeah, it's visible only, but we are getting a small screen. If you put the slides there, we can see the full screen.
Okay.
The slides at the end of the full screen. Yes. The third one. If you click on it, we'll see the full screen, sir.
You mean this one? I've done that. I don't know.
You can press F5. F5.
Last.
F5.
The bottom, sir.
I can see my full screen, sir. I don't know why you cannot see my full screen. When I did
that one. Yes, sir.
That's okay. Let us continue. No problem.
Naresh, I've actually sent you the PowerPoint presentation through WhatsApp. If you can share it also, that's fine. I'll just try to see why it's not showing up. Not stroke from a perspective of, oh, okay, there's something happening to the brain, and because of that there is a partial paralysis. It's not always the case. So stroke is a condition where the blood flow to the brain is actually disrupted, leading to either the death of the cell or damage to that area where these cells get insufficient supply of blood. And this might either result in the blood getting clogged in the blood vessel tube that are there in the brain, or sometimes because of some issues, the blood vessel in the brain gets ruptured. It just bursts out. So either you will have a block of blood clot in the brain blood vessels, or it might actually burst out and then the blood will actually ooze out of the blood vessel to the nearest regions within the brain. When it bursts, it's called hemorrhagic stroke. When it is just blocked and there is insufficient supply of oxygen to the brain in that specific area that's blocked, it's called ischemic stroke. Ischemic and hemorrhagic strokes are very common types of strokes, and nowadays they are trying to find something called atherosclerotic strokes, which is because of the quality of the blood vessel that supplies the brain itself. But stroke actually means for more than 24 hours, there is lack of oxygen and blood supply to one specific area of the brain because there is a block in that particular tube that supplies blood and oxygen to those areas of the brain, or because that specific blood vessel is bursted out and there is a leak of the blood in the brain, which is an issue. Why stroke happens? As I said before, there are two kinds of strokes, and it can happen through various reasons. Why a blood is not flowing properly to the brain, or why there is a burst in the blood vessel within the brain. It can happen through various modes. And if you see how it happens, so stroke is not necessarily happening because you identify these burst and block in a CT scan. It can happen because of some physiological issues like systemic hypoperfusion. It can happen because you end up with an accident where your brain is damaged. It can happen because of tumors. It can happen because of some malformations in the blood vessels and the nearest regions within the brain. It can happen through aneurysms as well. So there are so many reasons why you get ischemic or hemorrhagic stroke in a person. What could be the causes for these kinds of problems, primarily diabetes and hypertension are the two key causes of stroke. In addition to it, excessive consumption of alcohol, excessive smoking, previous heart diseases, taking medications of certain varieties which will lead to either the blood thinning a lot or a blood clotting a lot, hypercholesterol, obesity, and even physical stress could be the reasons. So there are two kinds of risk factors. One risk factor group is called non-modifiable. It is coming from the family, from the genes. And another risk factor is particularly these risk factors that is presented in the slide. When I say non-modifiable risk factors, for example, if you are in India compared to you in say United Kingdom, where I'm speaking from at the minute, people in India are prone for more strokes commonly compared to people living in the United Kingdom. So that could also be a factor. So where you are living, where your genes are, where your familial history is, it also constitutes the risk for stroke. So now if you look at the whole world, why we have to celebrate Stroke Day is primarily because of the screen, the importance of the information that you can see from the screen. Stroke is the leading cause of death as well as disability. And usually disability is measured through a factor called disability adjusted life years. And if you see this map, particularly on the left-hand side, you can see that stroke has been the leading cause of disability, both in developed countries as well as in developing countries. Over the past 40 years, so I'm not talking about something that is right now. For the past 40, 50 years, this has been the leading cause of death and disability. And if you can see how many people die because of stroke in the whole world, it is ranked 2. And this rank 2 has got more numbers. But the situation of this particular rank is there for the past 40, 50 years. So this is a huge global public health problem, which leads to a huge global burden of disability, because this is kind of a problem where you have partial paralysis and different aspects of the body, like thinking, acting, and feeling, all getting disturbed because of the lack of oxygen to and blood supply to the specific regions of the brain. Now, why it is important for India? Primarily because, as you can see from this map, whatever is there in red color and orange color is where the problem is exactly huge compared to the places where blue colors are there. Now, if you see, you might ask me, sir, in India, there's only little bit of orange and yellow color. There's no red color, but there are lots of blue color. But if you take a closer look and then move beyond the states and then go into the districts, the light colors are primarily going to be red. And those colors where you can see blue is primarily because we don't have data from those places, particularly in an Indian context. I'm trying to say, whatever data they would have had, they would have given that, say, for example, in Rajasthan, which is the largest state in the entire country in India, they might have said we had only 10 cases of stroke in a specific place. And if that data goes in, that's the data that's getting reflected in this map. But what I would like to stress upon from this particular slide is, stroke is a leading cause of death, but where does the leading or where does the rank 2 comes from is primarily from low and middle income countries. High income countries have got a very good system to understand and address the problem of stroke in their own countries, whereas in low and middle income countries who are affected by stroke, who are stroke survivors, do not have a system to be taken care of. Hence, the burden of this particular problem is tremendous in low and middle income countries, where India is also a part of it. Let's move on to stroke rehabilitation and care. So I just gave you a glimpse of why we have to look at stroke as an important problem and why we celebrate Stroke Day. And the celebration part starts here, but it starts with something called complexity, something it's very intense and something very challenging. So When stroke happens, brain is the central nervous system of our whole body. If you want to do something for something that had happened to brain, there are lots of things that's connected. So it's not just going to be a straightforward issue like a fracture. Where a bone breaks and then you do something, whereas the bone gets connected, and then you can actually perceptual aspects of the body and your entire participation in the society as a purposeful human being. And it will make you non-products when it comes to stroke rehabilitation. And whoever who's going to treat somebody who's got a stroke is going to be feeling themselves as somebody who's getting their head into the mouth of a crocodile. So it's not easy to say, oh yeah, I'm a person with stroke. It's not as easy as you think to take this challenge of doing in this picture. And each and every individual affected by stroke is going to have different problems, different aspects that are affected. So it's not going to be straightforward, and it will be like the picture on the right hand, on the left hand side of the, which is complex. Same thinking in 2011 is I have been a neuro rehabilitation occupational therapist since 2003, but I wanted to do something with my 10 years of experience working with people affected by brain injury, including stroke. And in 2011, I was in the UK treating people with stroke in the community. And I thought, wow, this is brilliant. If somebody gets a stroke, they are sent home as soon as they are medically stabilized. And then the whole team of people who are required to provide stroke rehabilitation comes to this person's home, treat them at every different time. And they get permission from the person who is living in his home with a stroke. How good is that, isn't it? So I just wanted to translate those concepts to an Indian context. So in 2011, I started my PhD from the London School of Hygiene and Tropical Medicine in the UK, trying to understand this problem. So what I did was, this was Tamil Nadu, where I did my data collection for my research, and I wanted to develop an intervention that can help people in the community affected by stroke and their family members see videos of how stroke should be managed, how stroke disability should be managed at home itself. But before starting to do that innovation, I went to their home and then I asked them, what is your need? What do you want from the perspective of rehabilitation? And as you can see from the slide, the first two needs, which are I went to about 200 people's home in the community living with stroke, and I asked them, what do you want from a rehabilitation perspective? And this is what they said. The first two things, if you see, information needs. So people did not know what is meant by stroke, how to identify a warning sign of stroke, and how to get rehabilitated after getting medically stabilized and then discharged from the hospital. They had no clue, and that is what you're seeing in this particular graph. So out of 100% of the population who I surveyed, you can see 92% of the carers did not understand how to manage a person with stroke in the community. They wanted information. And the similar situation with patients as well. And if you see the third important aspect, they said, what do you want? Immediate response would be, I want money. And they say money, not because they're asking for money to be kind of doing everything. They are asking money to be rehabilitated. They think that there's no money, there's no center which gives this kind of multidisciplinary stroke rehabilitation free of cost. So all that they were asking as a third important need is money. And if you see the fourth important need, it is all about the support they get from the family themselves. They needed somebody to help them within their family and or somebody else outside the family, because family members are very busy. And last but not least, I would just take those 5 important top priorities or needs of the people when they said this is what we wanted. The last one is community support. How far we look at providing support for this person to be able to engage in the community, engage with the family as usual, and then perform their roles and routines. So these are important components that came out when I asked people affected by stroke, about 200 people in the state of Tamil Nadu, what they wanted. Now, the people like you who are treating patients in hospitals and different settings, and I ask them what's happening. And you will obviously know this. People, especially in your third years and fourth years, you will understand that there are too many good, absolutely brilliant innovations that are happening. People are talking about using smartphone. People are talking about using computers, and everybody is talking about fantastic innovations that are happening on one side, right? But on the other side, what you all do not understand is, does all these innovations reach the people who are actually affected by stroke or not? Imagine if somebody in our own family is affected by stroke. Do you think you will get the sophisticated gadgets and innovations that are there for rehabilitation to you or your family member who is affected free of cost? And can you get it if you're not in Chennai and if you're in a different place which is far away from a city? So what happens in reality is, although people talk about several innovations that are there to help people affected by stroke, all these innovations are just lying inside the institutional setting. If a stroke survivor goes inside that setting, then he might be able to get that innovation, provided he has enough money to pay from his pocket. We don't have these kinds of innovations in government settings. And because of this reason, what happens is innovations keeps growing and people's burdens and needs also keep growing. So the difference is innovations are happening within an ideal environment, which is hospitals or rehabilitation institutes, but burden and need are exactly rising in the community. And this is one important primary reason why stroke has been the leading cause of disability for the past 50 years. Whatever is happening, whatever investments are happening only within institutions. It is not accessible by people who are experiencing the real problem. So the service users, the stroke survivors, the caregivers, their family members do not get to receive all these good quality innovations that are available at an affordable cost. Hence, inaccessibility to stroke care services has been a massive issue in low and middle income countries, including India. And it could be because the person itself does not understand what they should do after having a stroke, or their family members. It could be because of where you live with that specific stroke. So if you have a stroke, if you're living in the UK or in London, is completely different to having a stroke and living even in Chennai. And so the context matters a lot. That could be a reason. The third important reason is the amount of policies and programs we have in our country at a national level or even at a state level. The best example that I can give you in Indian situation is we have a national policy for non-communicable diseases, which started or developed and published in 2006. Under this program, there's an exclusive component for stroke. And in terms of the paperwork, the policy describes it beautifully, including having a physiotherapist, having an occupational therapist to help people. However, if you look at what is happening at district level, what is happening at sub-district level in taluks and mandals, nothing is there. We don't have a rehabilitation team working together in any primary health centers or even community health centers. So this is a huge gap in the continuum of care. And this is what I'm going to look at and then explain to you how I try to look at the situation and then try to derive a solution for addressing the issue of accessibility to stroke care in the context of Tamil Nadu. Of accessibility or inaccessibility to rehabilitation, not just for stroke, but for anything, is to look at what actually exists in our state or country. So if you look at your own place where you are from, all you can see is what is there on the left-hand side of this particular slide. So what exists? You have hospital-based rehabilitation services, but those hospitals are private hospitals, which will ask more money to be treated or to get rehabilitation. And these kinds of private hospitals are situated only in urban areas and predominantly driven by or led by a neurologist and a physiotherapist. However, this is not the way in which somebody with stroke should be treated. They should receive community and home-based services. So I was just thinking about what could change, and these could change. Hospital-based services can be changed to community-based services. Expensive private care available in urban settings can be made less expensive and widely available, and with all the important people who can help somebody with stroke, not just neurologist and a physiotherapist, which is not going to be providing them a continued comprehensive care when somebody is affected by stroke. So I clubbed these concepts of what could change together, and I thought these are the 3 key strategies that needs to be there in any intervention that we are providing for a stroke survivor in an Indian context. I understood that this has to be a community-based intervention because people cannot travel to hospital every day or rehabilitation center every day. So it has to be based in the patient's home or in the community itself. It should be firstly educational in nature. Given the information that I already said, people wanted education to manage the problem at their own home. So that should be the second strategy. And I also thought we don't have enough number of physiotherapists and occupational therapists and speech therapists and social worker or say cognitive psychologist to help somebody together. So we don't even have that in even an institutional setting working together. So I thought it's better to replace the human touch with technology, and hence those 3 strategies have been used, and it has been amalgamated to come up with an intervention called Care for Stroke. Right. So this is an intervention which is smartphone based. If you just type www.careforstroke.in, you will be able to register yourself either as a caregiver or as a patient. and this has got 4 language versions. Currently it is getting revamped, but it has got a Tamil version, it has got a Telugu version, it has got a Hindi version, and it has also got an English version. So anybody with a problem can access this intervention. And what does this app has is all videos. So say for example, it will tell you a section called activities of daily living, and if you click that section, there might be 2 to 3 minutes videos talking about how to wear a sari single-handedly, how to wear a dhoti single-handedly, how to eat with the affected hand, how to actually move from one place to another. So these are all videos of somebody who is actually a stroke survivor performing that, and the people affected by stroke and their caregivers can obviously see that and understand how to manage somebody with stroke disability at their own home. So that's the importance of this innovation. And this innovation is freely accessible. If you register, you can access this innovation. This innovation in 2015, I measured it for its feasibility and acceptability. So I wanted to know, in an Indian setting, can that innovation be used by people? Everybody has a smartphone. At least one person in a specific family has got a smartphone. So it was feasible. And I was also, and this innovation was not developed just from me. A group of key people, including the stroke survivor, and showed YouTube videos that was available for stroke. To see this particular animation, they said, no, this is looking very funny. Are we taking the seriously? I am having stroke and I'm struggling here, and you're showing some cartoons moving here and there. So they developed this innovation, and because they developed it, it was found feasible, it was found acceptable. They liked this innovation a lot. I gave this innovation free of cost for a month, gave them the innovation, taught them how to access innovation, used that every day for 30 days with which they have been allowed to use that innovation. So that's the acceptability of this innovation. Because it was acceptable in an Indian context, we have lots of private startups who want to look at these kinds of innovations, and I've been also working to look at connecting community of people affected by stroke with providers like you all who will be in hospitals, which is still getting tested for feasibility. In Malaysia is using the principles of the innovation that I had. And even there's an innovation in India called REVIN, which the government is now trying to take up and then provide to people affected by stroke who comes to government settings for care. So there are improvisations that are happening, and all these things are happening primarily to promote accessibility of stroke care to those people who are at home, who cannot access at their own out-of-pocket expenses. I will share the slides to you, and you can obviously go into the details of these innovations in all these countries. This is where in Malaysia we tried to look at working with those team, the social worker, speech language therapist. It includes physios, occupational therapists, the neurologist, and a technology professional as well. So everybody in Malaysia, we are working together and then looking at promoting such kind of innovation to help caregivers of stroke survivors in the rural regions of Malaysia. How can I do this? You might actually wonder how a small kind of innovation that was developed systematically and rigorously can get into different countries and promote access. So it was only possible because of collaborations. If you can see, we have so many academic institutions, research institutions, and government institutions. You can see Government of Tamil Nadu there because I have been working with them. I have been an expert committee member for the Tamil Nadu Rights Project, which looks at how to promote rights of people with disabilities and how to regulate the profession in the state. So without all these networks and collaboration, you cannot achieve what you want to achieve and promote a vision and help people with stroke in your own place. So collaborations are important. You cannot stick to your own organization and then say, no, I'm a physio, I cannot talk to an occupational therapist. You can't say that because a person affected by stroke or any kind of disability require both a physio and an OT. And sometimes if they have communication problem, you have to have that understanding that they are also professionals and then work together. And sometimes it's not just practitioners who is required. Sometimes you have to go to people in the academic institutions and then ask them for help to develop innovations based on systematic research as well. So it's a collaboration of lots of people, lots of experts. And last but not least, I would like to say you have to first collaborate with the people who is affected by stroke and their family. Without that, all these collaborations may go waste. So collaborations were very important in achieving what I have achieved so far. Now you might wonder, it's all flashy, right? It's all positive. There's no doubt at all. Lots of people are using it. Many countries are taking it forward. So the past 5 years, between 2017 to 2022, I was working on testing the innovation for clinical effectiveness. So first thing I did was between 2011 to 2015, I developed this intervention. And then I looked at whether this intervention is feasible for using and then whether it's acceptable in an Indian context. But last 5 years, I was looking at the third component, which is can this intervention reduce disability or not? So now, if you can see, the intervention was found feasible, acceptable, and I'm very happy to say that this intervention is able to reduce 40% disability more compared to somebody who's getting a standard intervention in India, in Chennai, in Tamil Nadu. But when I went back to these people affected by stroke who used this intervention for about 2 months this time, and there were about 350 participants who are affected by stroke. So it's not easy to recruit all of them in one day, and hence it took 5 years for me to run a clinical randomized control trial on this topic. They said, Suresh, we are sorry, this is not scalable. You can't make sure that everybody with stroke in Tamil Nadu can get this intervention, primarily because my intervention was focusing only on physical disability. They said, we have cognitive problem, we have speech problem, we have stress, we have mental health problem. So your innovation should be comprehensive to incorporate all those content as well. But importantly, what they said was, if you are saying this innovation is available, where can we get this innovation? Are we going to get it free of cost? Like you gave your phone, you gave internet connection, you taught us how to access the internet content on this particular intervention. But who is going to do all that in without you? Can government do it? Can this private hospitals where we are happy to spend and then do it? So there are lots of questions about when there is nothing in the system, how we can actually access this intervention. And most importantly, what they were asking was, if your intervention provides us with lots of details, say I am layman, I had a stroke, but if your intervention is telling me you have to get physiotherapy, you have to get regular occupational therapy, you have to get speech therapy, Now, where will I go and then ask for support? How do I access this intervention? Is physiotherapist, occupational therapist, speech therapist, all three together available in all the government hospitals, let alone the primary health centers and community health centers? But even in tertiary care hospitals, are they all available? Are they actually working together as a team, as you say in this particular intervention, is their question. So even if you strive so hard for 10 years, working on developing a systematic innovation to promote access, the systems and the context in place are not sufficient enough to move the idea forward for scalability. So you have to be very careful in getting into, and this is the importance of the second picture that I showed you, putting your head inside a crocodile's mouth, right? So if you want to create change, you should not lose your motivation by looking at all this happening. You have to strive forward and then do whatever you can. And I did that. So this is the reason why it is not integratable in any government setting. Say, for example, in this picture, you are seeing a pyramid, okay? And in the bottom of the pyramid is the health sub-centers, which we call as sub-centers or Anganwadi centers. We have 3,000 to 5,000 population there. And as you go up the pyramid, you can see in the community level. And if you see, for example, if you are in a remote rural region, and that specific region, the town part of it will have about 80,000 to 120,000 population. But when you move up to medical college level, this population is going to be in 25 lakhs. Okay. And that is where we have at least one or two healthcare professionals like us sitting. So all rehabilitation professionals at the minute in an Indian context are located or recruited from a government point of view in tertiary medical hospitals or district hospitals or sub-district hospitals, which cater to the needs of 25 lakh population. Okay. So for 25 lakh population, you have 2 to 5 physiotherapists per district, for example. And India has got about 800 districts completely. For 800 districts, even if you imagine at least having 2 to 5 physiotherapists, I'm saying even take 5 physiotherapists, you need 4,000 physios in each of these places at the higher level, let alone the lower level. So is it possible to have so little physiotherapists and then say we are providing good quality rehabilitation for everybody who is affected by stroke in an Indian context? We have 1.4 billion population in our country. So there's a understanding that you all as health professionals, our upcoming health professionals need to look at is we have an acute shortage of even one specific professional in a discipline which requires or in a condition which requires multidisciplinary professionals to be involved. So we are not who we are when it comes to saying we are great. This is reality, and this is why people who are affected by stroke think that ability is not going to be possible. I'm not saying this because I'm a researcher and I'm a teacher and I've done the research. This is coming from the people who are affected by stroke, despite me proving that this is an intervention that is feasible, acceptable, and effective. Professionals, because we sit in hospital, we treat people who are affected by stroke. What we don't understand is the context. What is the political, economic, environmental, historical, and who are the actors who is involved? Are we actually talking to any government people? No, we are just in a circle. We don't even talk to doctors who are not neurologists when it comes to stroke care. So we have to think about how do we promote access to stroke care by understanding the context, the actors, the content and structure. When it comes to content and structure, we as professionals always believe whatever you are doing to the patient is the best. We don't even ask them, okay, I'm giving you passive exercises. Do you feel any relief of movement? Can you walk properly after I give passives? We don't ask them that. So it's absolutely important what is the content, who are the actors involved, how the context is, and what processes we actually take forward to ensure we are looking at providing good quality, safe and effective stroke care in any setting that we are dealing with. So these are the issues that you need to consider. How we can look at integration. So this is my opportunity. So in India, we have something called health system. Any system whether it's a private system or a not-for-profit system or a government system, will have all those 6 points that is mentioned in the left-hand side. Okay, there will be a team that will provide services like doctors, therapists, and people like you all. There will be a system for providing supplies. Okay, in India, mostly we talk about drugs. Mostly we talk about medical equipments, but we don't talk about rehabilitation and therapy supplies. We don't have it. Say, for example, wheelchair in all the government hospitals. What's the quality? We don't know, but there is a system, there is a pillar, there is a department for products and supplies. Similarly, there's a department for recruiting people like us and then helping us work together in a setting to provide care. There is a system and there is a department to collect information and use that information for promoting the quality of services. There is a set department for getting the money and using the money. And last but not least, there is a department that will work on what are good policies to ensure that whatever the target is achieved. And if you could actually look at all these 6 departments or 6 pillars of a health system and compare your experience of where exactly the system is working, I think we can actually promise the person affected by stroke something that is feasible and acceptable for them. Doing relevant and rigorous collaborative research on why things are happening. So I'm not suggesting you to go and look at how and why brain rupture happens, how and why we can have problems like paralysis or spasticity. Why do you have to have, say, modified Ashworth scales muscle tone assessment of 3 to 4? Those are very clinical, but what people with stroke want is, how can I go back and be a productive member of the community? So your research inquiry should be relevant and it has to be done rigorously. You cannot say that I have 5 patients on experimental group, 2 patients on control group, and I showed statistically significant difference. That's not what we want. We want to see how exactly your intervention has helped the person with stroke go back and then live a productive life as a useful member of the society. That's what the research inquiry should target. But when it comes to research inquiry, this is information for you all because you're all students. If you can look at the left-hand side, that is what is happening. So as a student, you will learn, you will try and practice, and sometimes you might have interest in doing research and finding answer to a question. You will do research and it will stop there with your own department, with your own institution, with your own, BPT, BOT or master's program. However, there is a government system on the right-hand side, if you see, which wants evidence. They want to know how best we can incorporate the evidence that has come from academic institution into systems, policies, and pathways. And to ensure that everything happens, we do not need to just focus on scientific knowledge generation. We also have to look at practical knowledge, and we also have to look at political knowledge. And when all these 3 gel together, then you can have an evidence-based policy to get rid of the problems related to any person and with an evidence-based policy. So we have to. This is kind of a theoretical information that is coming from my experience, where I'm saying whatever is happening in, say, Abirami institution should be kind of disseminated and advocated to the health systems in that specific context, and then that should be discussed, deliberated, debated for an evidence-based solution to stroke care in that specific area where Abirami institution is working. So what are the implications for you? These are my suggestions, right? So if you want to do something for stroke affected people and their community in any context you're there, as a health professional, may you be a physio or a nurse or an occupational therapist, you have to first gain scientific expertise, okay? Not just reading book, but also by treating lots of people affected by stroke. So that's the first thing that I would advise. Not just sitting in the hospital and then treating people who come to you, but go to the community and then see how they exactly live after you discharge them from hospital with whatever rehabilitation you give. Because the real picture, the real realities actually come from the community. So you should gain field experience. Focus yourself on gaining only experience related to your area of interest. You should actually look at what earthquake happens, like you see in this picture, when conflict happens. Some approach that we can give to help people with stroke. Is it possible to actually address the same way you have done it when there was no tsunami, no earthquake, no conflict. So I've given a chair below just to say you that when I was working in Nepal with all these brilliant ideas in my mind, I was there asked to help people who are affected by gunshot, bomb blast, and landmines. But when I went there, I was helping people affected by amputations because of those conflict in Nepal. But there were also mothers who brought their children saying, I have a CP child, can you do something for them? So am I going to say no to them, saying I'm only interested in doing this? No. So when we went to camps, and then when we actually did artificial limb fitting and measurements and helping people there who are affected by amputation, the boxes that was there was used to develop a seating device for that child who had cerebral palsy to be seated rather than just lying flat on the ground. And this particular innovation has won the American OT Association's Innovation Award with $1,000 when I was just a student like you all. So I would like to stress the importance of do things, understand the communities and context before kind of trying to help people. You cannot just say, I have studied physio, I have studied OT, and I'm going to be a best professional with whatever I'm doing. Without understanding context, it's very difficult to make sure that you are doing something credibly important for those affected by a disability in any context you're working in. When you're working, you will gain so many experience. This will happen in the future. So it doesn't stop with publishing a paper in an article, right? It gives you credibility, but you also have to look at the reality. So there are people with 200, 300 publications. Is that enough? But the publication has to be communicated to the groups. And so you have to advocate for change. It starts with students. So I'm talking to you all as a part of that specific concept. So I'm advocating to you all that you need to do something as health professionals for people affected by stroke. You can see me in this picture there. So this was a training program where I collected people together and then trained them on how to help people with disabilities, not just stroke in an Indian context. But advocating change to just students and people who are already converted, like if I'm talking to you all, you understand better what is rehabilitation. But you have to also advocate going beyond to politicians and decision makers in the community. So this is an international conference I led in 2018, which talks about, as you can obviously see, evidence in global disability and health. And you have the Secretary for Telangana State on Disability. You have the WHO Southeast Asia Regional Office member who works on disability. You also have the Director for the National Institute of Empowerment of Persons with Intellectual Disability. So these are all big experts. So you have to advocate for change to politicians and decision makers as well. And you can see the disability commissioner signing an agreement with an organization which is doing research for people with disabilities in Telangana state. And again, I would like to stress the importance of collaborations. So if you cannot communicate properly, if you cannot connect to people uninhibitedly, it is very difficult to create the change you want to make in the community. So collaborations are very important. And you've got to be talking about it. And again, like advocacy, collaboration is not just within your own network. So it's not about just going to the next department and then talking to them, hey, I have a patient, can you treat them as well? It has to be at all levels. As you can see in Malaysia, there are three pictures. One picture is at the bottom, with something written in Malaysian language, and this is the community level. So this is just a rehabilitation center in a remote region of Malaysia, and the next second picture is the Ministry of Health, and the next picture is everybody who's involved in stroke care in the entire country. So we have Malaysian Stroke Council, the not-for-profit organization called NASAM, you have technical experts, you have app developers, you have Ministry of Health, Family Welfare and Education people in this particular picture. So collaboration must be maintained at all levels to ensure whatever you want is achieved. Please don't forget, the collaboration primarily has to start with the person affected by stroke. And then you speak about what their experience is, use your expertise, and then communicate and advocate for change and collaborate with whoever is required to make sure that whatever you want as a target is achieved. have been able to, so when I first developed the intervention in London as a part of my PhD, I won the International Student Innovation Award. So it's all gratifying if you keep understanding all these aspects that I just mentioned, collaboration, advocacy, rigorous research, and the ideologies of moving between whatever you're doing in the institution to the communities. With all those ideas, I was able to kind of gain lots of achievements. One of the primary achievement as soon as I developed this intervention was getting an International Student Innovation Award for the entire UK, which was gratifying. The work that I showed you in the graph. So I went to people's home and I asked them, what is your need? So after 5 years of publishing this work between 2016 to 2021, I was given an award from the American Congress of Rehab Medicine saying, this is the most downloaded research for those 5 years in the entire Congress. So Archives is a massive journal, and I was really happy that my research that's conducted in a small area in Tamil Nadu has been the most downloaded research between 5 years in the whole world. State Award for Research and Innovation from Government of Telangana by the Chief Minister. So this was given to me. This is the highest honor again from the government department for my work related to stroke from one state, acknowledged by the central government's Ministry of Social Justice and Empowerment as well. It's my achievement. So a good smile in one of the stroke survivor who I treated as a part of my research. This person is Basha. He has given me permission to, and he's basically given. He's one of the first patient who I saw. He was driving an auto. He was a youngster who had excessive consumption of alcohol as a risk for stroke. He had a stroke. He had a very young daughter. She was 2 months old when he had a stroke, and his wife was there to support him. Very difficult situation, but as time went on, he started to use my innovation. He learned more about how to manage himself after a stroke using the Care for Stroke innovation that I developed, and he's back in his. So he stopped driving auto, but he was able to get a government job in a water supply area, and this is where he is sitting. The phone belongs to me, so I gave that phone and the intervention free of cost to him to use it. You can see the pistol in his face. Whatever achievement I just showed you in my previous slides is not important. This is the achievement that I always have close to my heart, because this is why I have been working for the past 10 years to look at helping people with stroke, not just contributing to stroke care in the whole world. So the smile in the person affected is what will be a big achievement. So all your passion, all your enthusiasm, all your expertise should be targeted towards the smile. That it's all about bridging the gaps, and bridging the gaps does not stop with just treating somebody in a hospital setting or a rehabilitation setting. You need to look at connecting policies and interventions. Technology can help you do that. It can be kind of working out wonders to ensure evidence-based continuum of care. Community is important, so you have to be inclusive in thinking about doing something for them. If you're doing something for stroke, not look at yourself as the only expert, but also include people who are affected in your kind of intervention or innovation or your action. And that would be something that's very important to enable bridging the gaps in inaccessibility to stroke care that is always there in low and middle income countries context. So you have to look at systematically developing technology-driven scalable solutions, particularly in LMICs, which is of utmost priority and public health importance. And except you, nobody can actually initiate that process. So I would like to request you all to start thinking about these kinds of innovations for persons with disabilities. I'm currently working with for helping me learn all this, speak all this to you, and I'm finally very grateful for Dr. Naresh and the institution, Abirami Institution, and to you all about this important aspect of stroke on this special World Stroke Day. Thank you all. If you have any queries, you can actually contact me on this email address for further clarifications or disagreements or agreements and feedback. Thank you all very much.
Any questions, students can type your questions in the chat. Students are having any questions, you can chat. You can type your questions.
They'll not have any questions, I think, ma'am. Probably you can contact me through my email if you have any questions. But I would love to hear from you if there's any feedback, particularly from students, about this. Is it boring? Is it kind of creating a spark? Or can you please share your feedback about this talk, please?
Sure. Shall we wind down, sir?
Yes, ma'am. Yes.
Okay. We would like to extend our sincere gratitude for our outstanding presentation during our webinar on ensuring continuum of care for stroke survivors in India, held on 26th October. Your expertise and passion for the subject matter were evident throughout the session. Your participation in our webinar series has enriched our audience knowledge and experience. We appreciate your time, effort, and dedication to sharing your expertise. Thank you once again for your valuable contribution, sir. Thank you for joining us today.
Yes, sir. Thank you very much. Actually, you have accepted it, and I know that it is early morning, and I think it will enrich our students a lot, both for our occupational physiotherapy students. Thank you very much, sir.
Thank you, Dr. Naresh.
Thank you, sir. Thank you so much, sir. And thank you for joining us today. We appreciate your participation and hope you found the session informative. Stay tuned for upcoming webinars. Thank you so much, sir.
Thank you. Thank you all.
Thank you, sir.